And joining us now on the debate in Saskatoon, Saskatchewan, Stephen Lewis, the nationally renowned health policy analyst. In London, Ontario, Gary Switzer, CEO of the Erie St. Clair Local Health Integration Network. And here in studio, Natalie Mera, Director of the Ontario Health Coalition, and Adam Radwanski, Queen's Park columnist for the Globe and Mail. And as I welcome everybody in Points Beyond and here in the studio, I want to, remind you and our viewers that this is one of a number of programs we have done looking at the reforming of our healthcare system in the province of Ontario and nationally. And I guess I should tell you all, get comfortable. I'm going to do a bit of reading here because we want to do a bit of background. I'm convinced nobody knows what a LHIN is in this province. And we really do need to do a bit of background here. So Michael Smith, if you would, here's some of the background on what a LHIN is, the 411 on the LHINs. Started by the Local Health System Integration Act, which was passed by the McGuinty government in March '06, took authority April '07. So they're only 3 years and change old. It created 14 local health integration networks across Ontario. And just so you know, these don't directly provide service, but they oversee and are responsible for the following services in each region: hospitals, CCACs, the Community Care Access Centres, community support service organizations, long-term care homes, community mental health and addiction agencies, community health centres, divested psychiatric hospitals. The LHINs manage roughly 2/3 of the province's health budget, which is $46 billion plus this year, and the LHINs employ nearly 300 people across Ontario. So on paper anyway, they are very important to the smooth functioning of our healthcare system. But what are people saying about them? Here's what Adam Radwanski himself had to say in the Globe and Mail not too long ago. If it wasn't already before this week, LHIN is now officially a dirty word in Ontario. Short for Local Health Integration Network, the acronym has become synonymous with bloated, arm's-length bureaucracy, indifferent to Ontarians' concerns as it rams hospital reforms down their throats. And how about one more, this from the Ottawa Citizen? The health networks have come increasingly under fire. Conservative leader Tim Hudak has called them expensive, politicized, and, quote, a catastrophic failure. He says he would shut them down if elected premier. Adam, this is a lot of angry words about something that, as I suggested, I think people probably don't have any clue about what they are or what they do. Maybe they have a clue now that we've shown that list. Why is everybody so mad at the LHINs?
Well, I think, first of all, you've got to give a bit of credit probably where it's due to the opposition, because until very recently, I don't think anybody had heard of these things, except in some communities maybe, but generally they hadn't. I think what's happened is the opposition has done a better job of defining them than the government has, and the government hadn't really explained what they were, and nobody was really aware that they existed. Now they're at least starting to be aware, and the perceptions are not positive. I think the other thing is that there's, as usual, a lot of angst about where the healthcare system is going. There's a lot of concern about funding, a lot of concern about what stays open, what closes, et cetera. And there's a perception, at least, that the LHINs are the sort of remote entity that nobody really understands, that they're disconnected from communities. I'm not saying all of this is necessarily entirely fair, but that is the perception, yes.
Okay. Stephen, how about you on that one? Why is there so much bad stuff in the air about LHINs these days?
Well, I think there are probably 2 reasons. One is the reasons that Adam cited, but the other is that the anger is partly a result of the LHINs actually doing their jobs. The LHINs were set up to integrate services that weren't integrated before. That you couldn't expect programs to work seamlessly together. So whenever a LHIN started doing something to that effect and starting to try to address things such as value for money, coordination of services, and consolidation of services where you needed to on quality grounds or because you didn't have enough money, local people are going to get upset. And if you ask a local citizen, how do you feel about your emergency room closing? They're never going to say yes, but it may be the right thing to do under certain circumstances. So it's a very tough job that the LHINs have, and the more they are actively engaged in trying to solve some of these problems, I think it's perfectly understandable as they mature and they get their feet under them that some of this opposition is going to materialize.
Okay, Natalie, your group purports to represent the concerns of patients. How do you think the LHINs are doing?
I actually think that if their role was to coordinate services, if it was to identify gaps in services, to create a better continuum of care, et cetera, and if they had accomplished any of those things, I think that some of the concerns about the extra tier of administration and the high costs and so on would have been mitigated. But the truth is that the LHINs actually have not, in our research, improved access to care, improved the continuum of care, improved coordination of care. In fact, what's happening across Ontario is that whole categories of hospital care are being cut, and there is no replacement in the community. Rehab cut all over the place. No, at the same time as home care, rehab is being cut in the same communities. This is supposed to be happening under the planning functions of the LHINs, but nobody's actually paying attention. In fact, what we're seeing right now is, I think, the most chaotic, unorganized, unprincipled healthcare restructuring that we've seen. And that I'm including even the Harris era restructuring that we disagreed with vehemently at the time.
Get off the fence. Tell me how you really feel about it. No, okay, Natalie. All right, we get you. Okay, I should start by saying our producer for this segment, Sandra Jonas, probably called, I don't know, maybe she'll tell me in my ear right now, but lots of LHIN CEOs to see if they'd come on the program. Half a dozen. Okay, Gary Switzer, you're the only one with any guts who'd come on. So first of all, we're grateful for that. But tell us now, do you feel like you got a target on your back? And if you do, does it belong there?
You know, the LHINs have been very busy the last 3 years. We primarily work in the background, doing the planning and the funding. And when it's time for a decision, which we make those decisions in a public meeting by our board, where the public's invited, it's about change. It's about change, and it's difficult because these decisions are foundational, a lot of them that we make. And so all of a sudden we become a target for various groups about change, and then they try to find out who we are. We haven't invested a lot of time building our brand. We've invested a lot of time in getting results. And I'm proud to say, you know, we have surgical wait times now. You didn't have that before. You have ER wait times now. You didn't have that before. We have investments in the community to help people stay at home and live at home longer. So we're making a lot of changes locally, and it's done, you know, by a small group of people. We have 25 staff in our LHIN. We look after 3 counties. They're very dedicated. Our board is from the communities that we serve. And everybody's got to remember, we're patients as well in this system.
Okay, Natalie, I see you shaking your head already. What's the problem with what he had to say?
Well, I mean, the LHIN may have 25 staff, but they hire consultants all over the place. In fact, there's consultants crawling over the health system, making very expensive reports. And if they don't like the report that's been done once, for example, regarding the future of the Petrolia Hospital Emergency Department, a report that actually recommended expanding the services at that hospital by one of the physicians arranged through the hospital. The LHIN gets a consulting group in, and they create another report that goes the way that the LHIN wants in the first place.
You're talking about Gary's turf here, so Gary, do you want to speak to that?
Yeah, Petrolia is an excellent example. The doctors have approached us through the hospital and said they just don't have the resources anymore to manage 7 days a week, 24 hours a day. And our LHIN, we intervened and said that's not the way it's going to go. We're going to stop and review this. We're going to have experts come in and consult on this. And this is a community-based group that's looking at it, headed up by Dr. David Ng, who's our lead for emergency departments in Erie St. Clair. We have members of the public on it, elected officials on it as well. And they're reviewing this recommendation by the physicians and Blue Water Health. And we're looking at alternatives to keep that hospital open 7/24.
Let me get to Stephen Lewis on that one, because one of the things we've heard is that these LHINs are not all that accountable to the people that they are supposed to serve. Adam talked about the fact that most people don't even know they exist. There just doesn't seem to be a relationship. People understand the relationship between their local hospital and themselves, or their local community health center and themselves. They don't feel a relationship with the LHIN. Is that a fair comment?
Well, I don't know, but if people don't perceive that they have a relationship, then I take their word for it. Remember, though, that they're very new. It took decades for school boards to acquire democratic legitimacy across this country. Any new governance or coordinating mechanism is going to take some time to develop. I think one of the issues is it's not entirely clear how much power the LHINs have. It's not entirely clear which decisions government will reserve for itself. And when you leave local boards in place, which have been there for decades and to which the community has some sense of ownership or some relationship, it's not surprising that they're going to view another layer on top of that with some suspicion. I don't think there's anything the LHINs could have done about that, frankly. And if you look at the amount of consultation the LHINs have done compared to the amount of consultation that the local program boards did before, I would think the LHINs would come out quite favorably, especially in view of the fact that they're pretty lean operations. I mean, people are talking about this as if it's bloated bureaucracy. It's 300 positions province-wide in a system that employs literally hundreds of thousands of people. So whatever criticism one might have of the LHINs on that score, they're relatively inexpensive. Whether they're working properly, whether the division of authority is correct, and whether or not communities are ever going to relate to them as a sort of super community board or a county or a regional board versus their traditional allegiances to their own is a real question, which is why in most other provinces that regionalized, they took great pains to eliminate some power and even eliminate some boards at the local level.
Well, part of it is the bureaucracy, but Adam, part of it as well is that these folks on the boards are provincially appointed. And some people wonder, A, if these people are too political, with a capital P, too closely tied to the McGuinty government, and B, if they're appointed from Queen's Park, how exactly are they local?
That's true. In some cases they are, and some they aren't. But it's true that there is that perception that they're outsiders, that some kind of invading force. I do think what Stephen said a moment ago is important, though, that their powers are very abstract. And I think that is a problem here. And I think, to a large extent, they're viewed, I think correctly, as, to some extent, a buffer between the government and hospitals or the government and communities. Now, that's not necessarily through their own fault, it's through the way it's set up. But the problem is that if you look at where the real power lies, it remains in terms of discretionary spending, mostly with the government, with the ministry, and mostly with the hospitals. And so they're stuck. I know there's a lot of strategic planning that goes on. I don't mean to minimize the role they play, but there's not that much control they have over many of the spending decisions that are made. They're kind of a lightning rod, where it's easy to blame them. They have no connection to the community the way that hospitals do, so it's easier to blame them. And they sort of shelter the politicians a little, but at least I think that might have been part of the idea. It hasn't necessarily worked out that way.
Natalie.
Well, I agree with you, but I also don't subscribe to this notion that the LHINs, you know, the poor LHINs are sort of the lightning rod and stuck in a scheme that's not really of their doing. The LHINs have pretty, I think, quite a confused mandate under the legislation. It embraces a notion of integration that runs from coordinating services right through to closing them down, through to dissolving not-for-profit entities or organizations that provide healthcare services. So that's one problem. The second is that their regions are absolutely massive, and particularly in the north, they're just, you know, they encompass the size of several European countries, some of those regions. There's no transportation systems across those regions. There's no social, political, logistical, healthcare structures that actually work across those regions. And I think that is a fatal flaw to the LHINs in Ontario.
Let me follow up with Gary on that if I can, because, okay, the suggestion's been made, Gary, that the mandate of these things is not clear. You come to the job not with any particular background in healthcare, but with management expertise. Are you clear on what you're supposed to be doing?
My mandate is quite clear to me, and one of the reasons I joined this industry, because I thought the next 10 years are going to be significant transformation in the healthcare industry, and I wanted to be part of it. So my mandate's very clear. We're delivering on the key indicators that we have to for performance. We have aging at home issues that we have to deal with to allow people to stay at home longer, which we're dealing with. My board, very proud of the board. I couldn't tell which way they would lean politically. I mean, when you're at one of our board meetings, they ask very aggressive questions of staff, and they're very balanced, and they not only represent their local community, but they come at it from a system perspective. And with respect to the size of our LHIN, we have around 650,000 people, and I could be in front of any one of our providers within probably an hour and 15 minutes. And it's building these relationships that helps you build the integration in the future.
Okay, we heard the expression lightning rod used a couple of moments ago, and I want to pick up on that because if there's any provincial official who knows a lightning rod when he sees one, it's our ombudsman. And Andre Morin has recently had some interesting things to say about the LHINs. Michael, let's bring this up if we can here. This is from the Ombudsman's report, August 2010. Government officials touted the arrival of the local health integration networks as heralding a new era in community health care. Citizens, health service providers, and other stakeholders were repeatedly told by government representatives that under the LHIN system, they would have a voice in the health services decisions that affected them. The public was assured that with the advent of the LHINs, an aloof, centralized bureaucracy would no longer be making significant decisions about the future of community health services. Instead, Morin says, decisions would be informed by local needs and priorities and made in and by the community for the community. Unfortunately, while it is true that as a result of the LHIN model, the Ministry of Health and Long-Term Care has been able to distance itself from difficult decisions surrounding the integration and funding of regional health services, the reality of community decision-making has fallen far short of the political spin. Gary, I want to bring you back in because you know that the Ombudsman went on to say that some of these meetings that you guys have held have been illegal, they've been held in secret, the transparency isn't there, the accountability isn't there. Can you speak to all of that, please?
I can speak to the meetings we have in our region, and our meetings are public, they're announced, they're in the open. We've had education sessions in the past, both open and closed, which was one of our bylaws, where they were established that when you have meetings to inform your board with certain information, they don't have to be open. But we've had a combination of both, and we're pleased now to announce that all of our meetings are in the open. With respect to wading into making the decisions in the communities, Natalie brought up Petrolia. Our board is having a meeting in Petrolia when they have to review the recommendations coming from the committee that's looking at that. Actually, this month we're going to be in Wallaceburg. So we move our board around so they can make these decisions in the public eye.
Stephen, I think the Ombudsman was not referring to Gary's LHIN when he made the comments about illegal meetings and too much secrecy and not enough transparency. It was a more system-wide comment and focused on some of the other LHINs. In your view, does the Ombudsman have a point when he says that there's just not enough transparency and too much of an air of secrecy around how they operate?
I don't know, but I think that sometimes this is camouflage for not getting what you want. And when you talk about community engagement, community participation, and community-based decision-making, it really depends on how you pose the question. If you go out to people and say, what do you want? And they tell you what they want, but they're not asked to consider it in the context of real constraints, real choices that have to be made, and there are difficult decisions that have to be made, you're going to get wish lists, you can't fulfill them all, and you're going to catch hell for it. So, nowhere in the country has anybody succeeded perfectly in engaging a community and getting a community to accept a decision that it doesn't like, even if it is on most grounds entirely rational and logical and even necessary to maintain the quality of care. So I have a lot of sympathy with any organization that is mandated to consult with communities about what they want from their healthcare system. And I think if the community participation is really going to be useful, people have to come to the table fully aware of what the constraints are. And instead of just expressing their wants and preferences, they have to express them in the context of the real tough choices that LHINs, governments, and everybody else has to make.
Adam.
I think, first of all, I have to confess that the central complaint in the Ombudsman's report that too many decisions were made behind closed doors, I have to say I can't get that excited about personally, because I can't think of a lot of organizations that don't make a lot of key decisions behind closed doors one way or another. If it's not in a meeting, they're going to do one-on-ones over a beer or a coffee. I mean, people do talk quietly before they make decisions. That being said, one thing I've heard consistently in talking to people about healthcare around the province is that communication is absolutely key, and you have to be as transparent as possible what you're doing. Even the tough stuff, you have to communicate as clearly as possible. And what you're not going to do, you have to say. I mean, the problem is that if you're not out there spending much of your time talking to local residents, people are going to assume the worst. They're going to read all kinds of things into the uncertainties. And I don't know that LHINs have done an especially good job so far. I don't know if they were set up well enough to do this, to actually communicate what they're doing, what they're not doing, and how people should react to it.
Natalie.
I actually think that two things. One is that even if you don't care about democracy as a principle, and we do live in a democracy supposedly, and I don't believe that you can just change health policy or change fundamentally what you're doing in healthcare as it pertains, for example, to rural communities, without actually having some sort of parliamentary, legislative debate and discussion and some kind of mandate to do it. But even if you're not worried about that, I think we're talking about 47% of the provincial budget, and it's just bad governance not to have a meaningful feedback loop in which you hear from the patients, the whole people for whom this whole system is supposed to be run in the first place, about whether or not it's working.
But is that a LHIN problem or a Ministry of Health problem?
Well, it's both. I mean, people in communities now it's not a case that there are these sort of high foreheads that have come up with very reasonable decisions about what healthcare is needed in Ontario, and the unwashed masses just can't figure out, what their real priorities and values should be. The problem is that people are saying, well, wait a minute, first off, if you close my hospital, the next one's 40 minutes down the road. It's impassable in the winter. And by the way, even when I get there, I'm going to be stuck in a hallway or a storage closet for 4 days while I wait to get care. That's not reasonable, and no one's listening to them. And this is compounded by the LHINs because they're a political buffer, because the minister says, well, the LHIN has not recommended that I send in an investigator in that case, so I won't do it. The LHIN says, you know, we don't have enough money from the Ministry of Health. So nobody ever takes the blame for it. But at the end of the day, there's whole swaths of healthcare services that are being removed from reasonable access in communities across Ontario.
And let me follow up on the democracy angle. Gary, I wonder, do you see your role as essentially a managerial one? Your job is to manage, integrate better the services and resources that you've got, or do you see yourself as sort of another layer of democracy, which is supposed to be open to the public and listening to what your constituents have to say?
I think it's a combination of both. We manage, but we manage with insights from the community. I'll give you an example of some of our engagement. We had some difficult decisions to make about small rural emergency departments, and we had over 1,000 people show up at a gymnasium. It's a small town, 1,000 people. On the extreme side of that, we met with 20 homeless teenagers in a church basement in Windsor with our board, so we can help understand how they can improve access to health care. And so that's the type of range of the involvement we have, which helps inform our board when they need to make decisions and inform staff on how to manage the system more appropriately. But we also use this mechanism to add services. And we have an end-of-life program that we launched across the 3 counties. And we worked with the community to understand that people wanted their loved ones to die at home. They were dying in the hospital at a higher rate than anywhere else in Ontario. We instituted some aging at home funding, and we have these outreach teams. And now we have over 250 families in Lambton County alone that have decided to spend their last days at home with their loved one. That program we were able to develop that program through engaging those in the community, everybody from the residents to the care workers to the physicians.
Let me get Natalie on that. Do you object to any of that?
Yeah, well, first off, I mean, this is not the whole story. In the large meeting in Wallaceburg of 1,000 people that Gary's talking about, in fact, they had a PR firm that was hired. These were consultants hired by the LHINs that were absolutely despised by the crowd. If they had actually given...
How do you know that?
Because I was there. They actually...
They got shouted down?
It was our local affiliate that organized the meeting. The crowd was all given a little TV clicker, and the PR firm had actually put questions up on a board at the front of the room, and people were supposed to click A, B, or C as a multiple choice answer. This was their consultation on closing their local hospital that the community had spent 50 years building. People were livid. I've never seen, there was a massive opposition to it. People passed all of these TV clickers into the middle and en masse just refused to participate in this PR game.
Okay, let me get Gary. Is that kind of the consultation that, first of all, would you accurately characterize that?
We hired a facilitator for the meeting because we knew it was going to be a large meeting. And we stepped right into it. So once we didn't hide, we wanted to engage the people and we wanted to listen. We had board members there as well. And we listened. The public preferred to tell us, give us their information in a different format. And so we sat there and worked with them, and they lined up and talked to us for hours. So we adapted to that situation quite fine. But that's an example of us stepping into it and tackling these issues in the communities where we live and where the issues have to be resolved. Now, when you look at the model before the LHINs, I don't think you'd see people rushing out of Toronto to come down to our small communities and talk about change in healthcare. And this is part of the transformation that we're involved in today.
Okay, let me try this with Adam, because inevitably when something becomes a political story, and the LHINs have become a political story, you know, funny stuff happens. They start publishing Gary's salary in the newspaper, and you know, he hired a couple of consultants from Disney to come and share some management expertise. That got out. He had to cancel that. It became a big political football. I guess my question for you is, I mean, you write in my view, a reasonable, thoughtful, intelligent column in the Globe and Mail. Has this become a circus now?
It's getting there. It's getting towards circus level. I think what frustrates me a little bit is that a lot of what we're talking about and a lot of the real concerns don't have that much to do with the LHINs. Obviously, they're involved in it. But governments are making decisions to ration care. That's basically what we're talking about when we're talking about people having to drive further to the local hospital, not having certain services in their community. The decision is that with an aging population and with constantly new technology and new treatments that are expensive and so on, that you can't have your local hospital being sort of the one-stop shop. The problem is that the LHINs have basically been assigned to try and explain that to communities. I'm not sure they're doing a very good job of it, but there'd be frustration with somebody regardless. And the Conservatives were doing this in power, the Liberals are now doing it when they're in power. I don't doubt the next government will do it as well. So the question is there a better way to communicate? Is there a better way to implement it? But I'm not sure that it's fair to act as though these LHINs have come in and made these decisions as though they're this invading force. They're not.
Let me try this with Stephen then. Stephen, I know you're in Saskatchewan, but here in Ontario, we have obviously the Ministry of Health, which sets policy down at Queen's Park. You've got a Ministry of Health Promotion as well that's got its piece of the pie. You've got hospital boards, which are supposed to be making decisions about how hospitals do their thing. And now you've got these local health integration networks, which we've had for the last 3 years, which are supposed to, in 14 different regions across the province, kind of divide up and allocate resources appropriately and integrate services and all of that. Listen, you're the health economist, you're the expert, not me, but that sounds like, that sounds like a lot of management to do a job. You tell me if I'm wrong.
Well, Ontario decided, for its own reasons, to leave all of that social capital in place. You have multiple layers of boards where other provinces have eliminated at least a good proportion of them. My province had 435 health boards prior to regionalization, and it pretty much got rid of most of them, not always with the joyous consent of the populace, but people adapt. So, sure, it makes a difference, but I think Adam and Gary made 2 points that are fundamental here, and those are, this is really about change. Nobody set up the LHINs just because they thought you needed another level of governance. The idea was to make some significant changes in the Ontario healthcare system, which is needed just like it is across the country. And whenever you change something significantly in healthcare, you gore an ox.
No, I get that, but how do you tell if it's working?
Well, I don't think you can tell in 3 years. I think it's a long-term proposition. Now, you do have the Excellence in Healthcare Act. There is an obligation to get feedback from the citizens and from patients about performance. And Canada has been very slow off the mark in these areas, but we're starting to move forward. So the real question is, do you need some mechanism that will try to integrate services better than they would integrate on their own? And I would argue the answer is absolutely yes. Are the LHINs the right mechanism? Do they have the right mandate? Have they done a perfect job? Obviously, perfection is elusive in healthcare. And on the communication side, I think by and large, it has been very difficult in healthcare to get good, effective communications because most of the time, people aren't interested in communicating with the healthcare system until they don't like something. And then it's not a particularly civil conversation because people are angry. So you can hold a town hall meeting and you can get 1,000 angry people out. You can't get 5 people out to a regional health board meeting in Saskatchewan unless something is annoying people. So it's a two-way street here. If you want more democracy, transparency, and participation in healthcare governance, citizens are going to have to step up to the plate, not just when they're angry and they want to preserve something, but when they actually want to learn something about the complexities of the entire system and maybe contribute to making better decisions.
Now, I appreciate that, but Gary, maybe you can help me with this. We want to get a better understanding of where the buck actually stops. So do you tell your hospitals in your part of southwestern Ontario, here's what we're doing, or are you taking direction from them? Or does Queen's Park tell you what to do, or are you telling Queen's Park, here's what we're going to do? How does it work, actually?
With respect to funding, we have guidelines that come down from the ministry, and then we engage the hospitals in agreements for that funding. And we have performance agreements that they sign on an annual basis, and we monitor them on a monthly basis. And so with respect, if a hospital wants to close, let's say 6 or 7 beds for a reason, they have to have our approval to do this. They can't do it unilaterally.
So they're answering to you?
They're answering to us, because as you know, if they make a change, so in the past they would make a change, which essentially just moved the problem elsewhere. Well, now they can't do that. They have to think as a system.
And what if you say that you sign these agreements with them to fulfill certain things and provide certain services? What if they don't?
What if they don't? We have the authority to intervene, and there's penalties that we can impose. And then if things really get unruly, like you've seen in some parts of Ontario, we work with the ministry to bring in an investigator or a supervisor.
Are there enough checks and balances in all this as far as you're concerned?
That's not my description. That's not really reality at all. I mean, for example, in Burk's Falls, the local hospital was closed down. A month before that, the mayor and one of the councillors went to meet with the LHIN about 5 weeks before the closure of the local hospital, and the LHIN claimed that they hadn't heard about it, something that had been on the front page of the newspaper all the way through. In Niagara, on the other hand, the LHIN had to approve a hospital improvement plan. It's a multi-100-page document, et cetera. It's scattered and extremely chaotic across Ontario. So does it not...
Scattered and extremely chaotic?
Yes.
Does that sound right to you, Adam?
It's scattered for sure. I think there are different standards in different places, and that's part of it, is that to some extent the LHIN seems to be what you make of it. It seems as though if it has strong leadership, it'll take initiative locally, and if it doesn't, it won't. And of course the problem with that is it becomes harder to attract strong leadership because its powers are so undefined in the first place. So I do think there is a problem that not every LHIN functions the same way, yeah.
So in Alberta, they went through all this. They created these regional authorities, and then they decided a few years later they weren't working. They blew them all up, and they've centralized again, sort of. Stephen, let me bring you in on this. The opposition leader here in Ontario, a guy named Tim Hudak, has said that if he wins the next election a year from now, he's going to blow these things up. They are out of business. He hasn't said what he'd replace them with, but he has said they'd blow them up. Do you think that's a wise move?
Be careful what you ask for. By all accounts, morale remains terrible in Alberta. There is a huge lack of local input into healthcare decision-making. You've got one authority, the Alberta Health Services, that is trying to run the entire system, and they're not happy campers in Alberta. So there was no plan in Alberta. It was done rather hastily. The government said, we don't have a plan on what we're going to do to compensate for the loss of the regions. They've now set up administrative zones, but there is no local governance there. So I wouldn't say that at this stage anyone objectively would say that Alberta's been a screaming success. And I would say also, you can blow up the LHINs if you want, but if you don't have a plan for some form of regional integration of services where you can make these allocative decisions, where you can plan on a wider basis, where you can make sure the gaps in the system don't persist, then you're leaving yourself the way the system was 5, 10, 15 years ago. And that is why every province in the country, in one form or another, moved to regionalization. Because Alberta has retreated from it and Prince Edward Island doesn't mean that they're a bad idea. Maybe there are problems in execution, as there will be with any structure, but I think if I were the leader of the opposition, I would feel an obligation to say, how am I going to integrate services at the local and regional level if we don't have these bodies?
Okay, a few minutes to go here. And Gary, I'm just curious, have you met with Tim Hudak, or have you talked to him about this yet?
No, not at all. But you know, my messaging here is, you know, we're 3 years young. And when you start something like this, you jump into the shallow end of the pool. You don't jump into the deep end, which is exactly what this ministry has done, and I think it's the right move. And now we're, you know, this July, 2 months ago, we received the funding for the long-term care sector. So you can see we're evolving in the right direction, and I think we need to continue. We're making great strides with a lot of surgical programs, a lot of our regional programs that we're launching as well. So I believe it's the right thing to do, and we look at it from the patient's perspective and their outcome and their flow through the system. And 95% of our residents in Erie St. Clair receive their care in the community. And so we're the group here locally working with them and working with the providers to ensure that that care is optimized and that it's a positive patient outcome.
Tim Hudak's position, Adam, got a lot of attention when he announced it last week, I guess. He said, we're going to cancel these things. They're no good anymore. Yeah. Do you think that's a sound position to take?
Politically, yes. This thing is a gift horse for Tim Hudak, because for Conservatives, it's usually very difficult to talk about healthcare, because as soon as they start talking about it, particularly in Ontario after Mike Harris, they get accused of wanting to cut things. Here, there's something they can actually say they'll cut, and people actually like that. I mean, that's pretty much a perfect political opportunity for them. So I don't think they're looking all that seriously yet, at least, at the policy side. But I do think they saw an opportunity, and they've gone with it.
Does he have an answer yet for, if we kill these, what do we replace them with?
No, he doesn't, and he would tell you as much himself, I think.
Do you think he needs an answer to that?
Soon he does. It does seem to me there's two options here, and I think we know which one he's going to take. But if you want these things to function properly, you're either going to have to eliminate them, in which case just give up on the idea, or you're going to have to make them a lot stronger, which is something Stephen touched on earlier, which would mean, in a lot of cases, either dissolving hospital boards or at least minimizing their power.
That's controversial.
Now, if you're going to undertake that, I mean, touching a hospital board is really tough to do. But that's part of the reason it's so hard for the LHINs to get things done, or the government to get things done. So in the long run, that might be something the current government, thinks would be a good idea. I can't see them promising it either, because it's such a headache to take on.
Gotcha. Natalie, how about it?
I agree with Hudak, which is unusual.
You blow them up.
Yeah,
Natalie Mehra and Tim Hudak together again. I never thought I'd see it.
But the truth is, I mean, we've recommended, we had a panel that traveled the province. We heard from more than 1,150 people, and the total consensus from dozens of mayors, nurses, doctors, paramedics, local citizens was that healthcare had not improved, coordination had not improved. Services, in fact, were at more risk than ever.
Gary says it's 3
And
years. You got to give them a
um,
little more time.
Well, you know, it would be one thing if it was 3 years and there was any admission that there were serious problems, that that people needed to be listened to in a much more meaningful way at this point, that there's some real chaos in infrastructure and planning and patient care, and the huge cuts to chronic care and rehabilitative services.
Let me give...
None of that is even being admitted, so I don't have much hope that these very political bodies will change.
I feel an obligation to give Gary the last 20 seconds here. Gary, when will we know if these are working to the kind of satisfaction that we expect they should work at?
Well, you know, once again, we focus on the patient experience, and we do a lot of small things in each region. Could be improving transportation for dialysis patients because they need to be transported back and forth to a hospital, to the end-of-life teams that I talked about, to the region being proud of their wait times for cataract surgery, hip and knees, or MRI. Things are improving. Once again, we work behind the scenes to move the system forward. We have our five hospitals in Erie St. Clair working together on an operational review. That would never happen before. They would end up doing individual reviews and never share the information.
Okay, Gary, you got to forgive me. I got to jump in because that's our time.
Gotcha.
Let me thank Stephen Lewis very much for being there on the line for us from Saskatoon, Saskatchewan. Gary Switzer, the CEO from Erie St. Clair, Lynn. He's joined us from London, Ontario today. Natalie Mera, Adam Radwanski, thanks so much for your help as well.